I'll start with the case. Patient came with complaints of pain in the left popliteal region and in the left leg for 1 month duration. There is complaints of dilatation of the left leg veins and the popliteal veins for 1 year duration. History of presenting illness, complaints of pain in the left popliteal region and left leg pain, which there is a continuous dull aching pain, which aggravates while standing and walking and gets relieved on lying down and sitting for approximately 15 minutes. His VAS score approximately is 7. There is no color changes visible. No history of color changes. No history of ulcer. No history of prolonged immobilization. There is no history of constipation and no history of swelling in the abdomen.
So can you briefly tell us what is the patient's complaint?
The complaints of the pain in the left popliteal region and the left leg for 1 month duration.
Patient is having pain in the left leg.
Yes, sir.
And any other symptom? Any other complaint?
And dilatation of the veins, sir.
The patient is aware of the patient is aware of dilated veins. Or patient is aware of prominent veins in the same leg.
In the same leg, sir.
Okay, so that's and if a patient is having visible prominent veins, what does it mean?
So there is increased venous hypertension and there is dilatation.
What does it mean? It means that the patient may be having varicose vein.
Varicose vein.
So on the face of it, we now know, right in the first two sentences that the patient is having possibly varicose veins. Now, in this context, what kind of a history we need to take so that our history is complete? What all do we need to keep in mind while taking the history in a patient of varicose veins?
Pain aggravates on standing and walking, sir.
Anything else?
And it takes more than 5 minutes for it to get relieved, sir. Approximately 15 to 30 minutes, sir.
Okay.
क्रॉस चेक करना है कैसे चेक करेंगे रजिस्टर लॉक तुम पहले दवा दे दो दवाई ले आओ फटाफट
Yes.
Sorry for the disturbance, yeah.
Is that all?
I mean, if there is any history of color changes or ulcer, we have to look for, sir. Any history of ulcer, especially in the medial part of the leg, sir.
So first and foremost thing is that we should know what are the symptoms of varicose veins. So can you tell me what are the symptoms of this what are the symptoms of varicose veins?
Sir, dilatation of the veins, pain.
That is now I think behind us, because we know that because of the dilated veins or because the prominent veins, we are considering the diagnosis of the varicose veins. So what are the symptoms of the varicose veins?
Dull aching pain, sir.
Dull aching pain. Okay. That's all.
Then history of ulcer, sir.
Or so you should remember, when the patient presents to you with the varicose veins, you have to look for the various symptoms that the patient may have. Why is it important to know for the various symptoms that the patient may have? So we'll come to that, but it's important for you to know what are the symptoms. So the symptoms are, one is pain, which Shyam has also tried to explain to you. Another symptom is some kind of a hyperesthesia. Another thing is venous claudication. Now, venous claudication, you have to understand, venous claudication is something like a bursting pain which the patient experiences on walking and doing some activities, and which takes time to go away. It is quite different from the intermittent claudication, which is because of the arterial insufficiency or chronic limb ischemia. So you should be very clear, what we are dealing with. So neuropathic pain, hyperesthesia, some kind of cramps, and venous claudication. These are the things that you should, in all the context of pain in the leg, you should be clear about what is venous claudication, what is neurospinal claudication, and what is intermittent claudication. So these are three important things, and I think you should make up a clear definition in your mind, pick up the right definition so that you are able to blurt it out when asked for. Okay, then we have to look for could it be a secondary in the whole process? Could it be a secondary varicose vein, or it
Yes,
could
sir.
be a primary varicose vein?
We need
So
to
what
rule
is
out any abdominal tumor.
what is secondary varicose vein and what is primary varicose veins?
Sir, secondary varicose vein is associated with other diseases like maybe abdominal tumor, right heart failure, associated with other diseases. Primary is just incompetence of the valve, sir.
What is the commonest cause of secondary varicose veins?
Right heart failure.
No.
Abdominal tumor.
No.
For pregnancy?
No. Deep vein thrombosis. Somebody wrote it right. Rakshit Pancholi is right. It is deep vein thrombosis and post-phlebitic condition in which the deep venous walls are destroyed and there is a reflux through the communicating veins or perforating veins. So why didn't it occur to you? So you have to take a very good history of deep vein thrombosis. And you mentioned in your history about immobilization. You asked this history for the right reason, but you didn't know why are you asking this history.
Yes, sir.
Okay?
Yes, sir.
So the most important thing you remember is deep vein thrombosis, and in your history, make all the attempts to sort of exclude this particular diagnosis. And of course, then you have the pelvic tumors. That is one particular thing which you should be aware of. But that's one that you in the history would do all that you can to exclude the diagnosis of a deep vein thrombosis. Okay. Then you should know about the complications. So what are the complications of varicose veins?
Sir, ulceration.
Ulceration. Now, if you take so much time to tell me about the complication of varicose veins, that means that you have not read it enough. What are the complications of varicose veins?
Sir, coronia phlebecticae.
No,
don't
go into those things, you know. Let's be on the ground. Let's not try to go deep inside. Somebody says hyperplasia, skin pigmentation, ulceration, and thrombophlebitis, and bleeding from the varicose veins. Right? An ulcer can bleed, or there could be a bleed from the varix. Okay. So you have to be very clear about this particular entity. So you should know what are the complications of varicose veins, and in the history, you know, try and have an idea that you mentioned that there is no history of ulceration and things like that, but you should be very clear that in history you're making that attempt, you know, to find out whether the patient has any complications of varicose veins or doesn't have the complications. And you remember, you know, what are those things? You know, superficial thrombophlebitis. Then you can have ulceration, bleeding from a dilated vein, pigmentation, okay, and things like that. So, and very, very important thing, don't forget about this. This is an acquired cauda equina syndrome. Do you know what is acquired cauda equina syndrome? Anyone?
Yes, sir.
What is that?
Sir, patient walks with the heel above, sir. Just to the toes he walks. Due to and when he keeps on walking in that manner, he gets a acquired cauda equina varicose vein.
Why does he walk like that? Can
Sir,
anybody answer that question?
So to relieve pain, sir.
No. Can anybody answer that? So I'll answer this question. You just note it down. Somebody has written. It is because of ulceration in this region. There is fibrosis of the tendo-achilles. As a result, there is a shortening, and then the patient tends to walk on his forefoot, elevating his heel. So somebody gave the right answer, and that's the right answer that you should know. Okay. Now, why I'm giving stress on these factors? Why it's important to know all of these things in the history?
So the equinovarus is a common deformity in varicose.
No.
Complications. It is a common complication. It is a complication of varicose.
No. You should know that all complications and all of these things that we are mentioning could form the indication for surgery for varicose veins. When I'll ask you what are the indications of surgery for the varicose veins, these would become even more important, right? So that is the reason that we are asking you about complications of the varicose veins. Remember, so complications of varicose veins, you should know, you should be able to enumerate these complications, and at the end, some of these complications would be the indication for surgery also. So I think in the passing, this will be very important. Now, what else do we need to know?
I mean, the personal, history is there, sir. I mean, whether what kind of work does he do, sir? Whether there is long-standing.
Yeah, well, what is the importance of this particular history?
Patients who stand for long duration are more, they tend to have varicose veins, sir, due to increased intravenous hypertension.
So what? How does it impact our treatment, or how does it impact our approach to such a patient? How does it impact?
Sir,
Anybody? Yes.
Post-surgery
Yeah, that's the right thing that somebody has written. It's a recurrence. Because after surgery, the chances of this recurrence is also high if a patient continues to have this, and you'll have to be doing some kind of a counseling of this patient. Change of occupation may not be possible, but then you'll have to tell him, that he'll have to be taking care of his standing posture, either by way of using various types of stockings, pressure gradient stockings and things like that. So it's a question of now be clear about the recurrence, right?
yes, sir.
So, okay, what else do you need to know?
Sorry, in this is a male patient, but in female patient, we can ask history of OCP intake.
How is that important?
There are more chance of DVT, sir, in those patients, sir.
Well, that's okay. That's understandable. But okay, that could be that OCP, DVT, and post-diabetic condition. Okay, we can understand that. What else? If your patient is a female patient, is there anything else that
Pregnancy,
can be,
sir.
that
Pregnancy,
important?
pregnancy,
No.
obesity.
No. Iliofemoral venous thrombosis, pelvic pain, and varicose veins. So this is a combination, and that will happen. That can happen in a female patient. So if the patient is having a history of pelvic pain, a female patient having a history of pelvic pelvic pain, and then she has also, let's say, vulvar varicosities and varicose veins, then this is a kind of thing, which will fit into iliofemoral type of obstruction with varicose veins. So I think all of these things become important, and you should, while taking history and examination, keep these things in mind. Okay.
Yes, sir.
So history is a very, very important thing. And in the history, you have to have a very wide kind of a spectrum, very wide canvas where you will have to fill in all the spots and all the places with the right color. Okay. I think we have discussed and dissected history, and today your history was found to be a little skimpy and superficial. I will ask you to make your history more meaningful and more elaborate.
Yes.
Chalo, move on.
Past history, history of right side total hip replacement on right side last year, sir.
Yes.
No issue of diabetes, hypertension, or tuberculosis. Moving on to, no issue of any other drug intake. Personal history, patient works in an industry with long standing hours, 12 hours approximately. For the last 1 year, he has not been working after his surgery, sir. He is having normal bowel and bladder habits. History of tobacco chewing present with 5 packets per day, sir. There is no history of smoking. History of alcohol intake, 4 pegs once a week, sir.
So in this somewhere it also becomes very important that when you take the history in a patient of varicose veins, you should also be taking focused history about lower limb ischemia. Sometimes some of these situations may coexist. So while you are doing the history, you have to be quite focused that you are also simultaneously ruling out lower limb ischemia or arterial insufficiency. So as you very rightly said in some of those points is, diabetes, tobacco chewing, this becomes important. And, if the patient is having ulcer, the distribution of ulcer, where the patient is having any ulcer, and importantly, any rest pain, right? Or any gangrene if the patient has developed, that also should be mentioned. So when you're taking the history of varicose veins, don't forget to mention about symptoms which could be referable to lower limb ischemia, right? So the history is not complete without giving a focused kind of impression, making a focused kind of impression that either there is or there is no evidence of chronic limb ischemia. It also becomes important. I'm opening up the discussion further. It also becomes important when you are examining the patient of varicose veins, make it a point, to also rule out lower limb ischemia. Okay. So
Yes.
that will be always there, in patients of varicose veins. So this is a focus that you should not lose sight of. Another one point that I forgot while we were discussing about varicose veins, in the secondary varicose veins, AV fistulas are also very important. And if there is a history of trauma, significant trauma, maybe patient has got an injury to the artery and vein, and the patient has developed a traumatic arteriovenous fistula, as a result of which, now the blood is getting, the pressure of the artery is being communicated to the vein. As a result, patient tends to get what's called as secondary varicosities. And these varicosities are because of what is called as arterialization of the veins.
Also,
So
Park-Weber syndrome, sir, which is also causes AV fistula.
Chalo, I ask you a syndrome. Since you have mentioned a syndrome, I'll ask you a syndrome. And anybody can answer that. What is Nutcracker's syndrome?
Sir,
It is
associated with,
relevant to this. That's why I'm asking you this.
associated with May-Thurner syndrome.
I'm asking you about the Nutcracker syndrome.
Sir, in females, it is.
Who's this person who's on left renal vein compression by what? Yes. One more thing. Left venous, compression, left renal vein compression by which are SMA. Great. So that's the right answer, Nutcracker syndrome. And it will result in varicocele of the left side. So SMA, because left renal vein has to join in inferior vena cava to when it turns towards the right, it may be compressed by SMA and can give rise to compression, as a result of which patient can have varicosities, especially of the scrotum and the perineum in the male patient or in the female patient too. Right?
Yes.
So remember, there's some entity called Nutcracker syndrome. Somebody may ask you just for the fun of it. It may not be that important in the context of varicose veins, though. So it's a vast subject, and I would want you to read this subject thoroughly from whichever book you want, but you must read it thoroughly. In the run-up for this presentation, I brushed up my subject with Sebiston. I think it's a very good coverage of this topic in Sebiston, and you can do well to, go for it and read it. Okay. Ciao.
Family history, there's no relevant family history. And moving on to general examination, sir.
Mm-hmm.
Hope the screen is visible.
You can enlarge this. You can make it in a slideshow. Yeah.
Patient was conscious, oriented, and comfortable with Karnofsky scale 70. BP is 130/80, pulse rate is 88 per minute, and saturation is 98%. There is no pallor, icterus, cyanosis, clubbing, or lymphadenopathy present. On inspection, dilatation of veins were noted in the medial side of leg, thigh, and the popliteal region. There was localized swelling in the popliteal region was found. Pigmentation was present at the popliteal region. There is no ulceration present. And on the right side, few blowouts were present at the medial side of the leg. This was the inspection, sir. Moving on to palpation. These are all the pictures. Yes, sir. Moving on to palpation, there was warmth noted in the left popliteal region. There was tenderness, minimal tenderness present. There is no thickening of the skin. There is no edema. There is no redness noted. Moving on to the various tests performed. First, for SF incompetence, Trendelenburg
you have to tell us about this complications of the varicose veins. Are there anything related?
No ulcer, sir. No edema. There is no edema. No thickening of the skin. No ulcer noted, sir.
So I think it's a very, very important thing, to mention. And some of these things, you should be very clear. What is lipodermatosclerosis? What is lipodermatosclerosis?
Sir, lipodermatosclerosis is a pigmentation of the Gator's zone, sir. It is a typical pigmentation of the Gator's zone. It is also known as champagne glass appearance, sir.
No, I think you are confusing all of these things. Lipodermatosclerosis is scarring. It's the scarring of the gator area. And what is the gator area?
Sir, it is the medial side of the leg, just above the medial malleolus, sir.
It is that part of the leg just above the two malleoli, right? Why it is called gator?
Sir, it is above the medial malleoli or between the malleoli, sir?
It is just above the both malleoli, and that's the part which is called as gator.
Yes, sir.
Right. That's the part where the this leg is the thinnest.
Yes, sir.
So what is gator? What is the spelling of gator and what is gator?
Gaiter.
Yes, it is. Gator is this Gaiter, and it is that the gator was some kind of a some kind of protection that was worn by the warriors in this region, because if you this is the area which can be very easily sort of chopped off by a sword. So to avoid that kind of an injury, they will reinforce this area with certain kind of protective gear. That was the term for that was gator. So gator area is the one where the maximum dermatosclerosis occurs. What is the pathogenesis of this lipodermatosclerosis?
So there are white cell trapping. I mean, one is due to the venous hypertension. There is white cell trapping theory. And
why in this particular area?
Sir, it is where the great saphenous vein ends, sir. It's the most common area for dilatation and complications.
You should understand this, that perforators join the great saphenous vein at the right angle. Right? When something is joining at the right angle, the pressure will be transmitted in an end-on manner. And that is why, this is an area where there is a perforator, where there are few perforators. And if you ask the number of perforators, that could be about 100 perforators have been identified. Okay. So as the perforators are, this is an area of a perforator which commonly becomes incompetent, and once this becomes incompetent, the pressure is transmitted in an end-on manner, because this perforator is joining it at a right angle. So what happens is that these leukocytes, etc., they leak in this particular site. There is a fibrin cuff theory which results in poor hypoxia, poor oxygenation, and as a result there is a fibrosis, and that fibrosis also has some kind of a depigmentation. It's not a heavy pigmentation, it's light pigmentation, and that is what is called as a lipodermatosclerosis, right? And when that progresses further, it can also cause fibrosis of the tendo-achilles, and patient can go to what's called as acquired chorda equina syndrome. So remember this particular thing, lipodermatosclerosis. It's because of this lipodermatosclerosis, because of scarring, that what happens is that this area shrinks, and that becomes like the stem of a champagne glass. So that is why this in the region of the calf, that is in the region of the calf, and lower down. Lower down is the stem and up is the glass. So glass is there as it is, but the stem becomes narrow, and that is why you give it the name champagne glass appearance. Okay.
Yes, sir.
That is because of fibrosis.
Yes, sir.
Now, that is also the reason for ulceration. The ulceration occurs because of the poor oxygenation in this particular area, resulting in poor oxygenation, resulting in poor healing. And there's one more thing which you should know, which we were talking about the symptoms, and that is itching. Itching is because of hemosiderin deposit. So itching, constant scratching, poor oxygenation because of the factors that we have mentioned, that sets the stage for the ulceration to take place. Okay. Now, if I were to ask you, how will you differentiate ulcer from varicose veins to the ulcers from the arterial insufficiency? What will be your answer?
Sir, first it is typically located at the gaiters zone, sir.
Okay, so you have understood what is gaiter. Now it is these ulcers are located in the gaiter region, generally above the medial malleolus.
They're associated with the dilatation of varicose veins, sir.
Yeah, there could be, or sometimes if there is a deep vein, if the superficial veins have not dilated, they may or may not be there. Okay. What else? Anybody? Apurva. Arterials are punched out, pale or no granulation tissues. Yes, arterial ulcers are quite superficial, right? And they are punched out. Okay. What else? It's a very, very important thing.
Venous ulcer, usually they have sloping edges, sir.
Anything else? Bhavna says risk factor like hypertension, diabetes. That's okay. Hardeep says arterial tip of it. That's the most important answer. Arterial ulcers are located in the most distal part of an ischemic extremity. Remember this word, most distal part of a ischemic extremity. And there will be telltale features of arterial insufficiency. That's right. That telltale features, can somebody say what are the telltale features of insufficiency? We were discussing today pulses. You would always see for pulses. Okay.
Decreased
Then
pulse.
loss of hair. Yes. Shiny skin. Right. And brittle nails, thick and brittle nails. All of these suggest that the patient may be having arterial insufficiency. Okay. And these arterial ulcers are extremely painful. Remember this word. If if the patient has superficial ulcer in the most distal part of the extremity, that is showing features of ischemia, as very painful, it has to be arterial ulcers only. Venous ulcers, by and large, are not painful. They are large, have sloping edges and serpiginous margins. So you should be always able, and of course, there will be telltale features of arterial insufficiency on that side. On this side, you would find features of varicose veins. Okay.
Sir, just a doubt, sir. Diabetic ulcer, they also come under arterial insufficiency.
No. Would somebody answer this question? Diabetes ulcers could be because of infection, they could be because of neuropathy, or they could be because of arterial insufficiency. So there could be ischemic ulcers, there could be neuropathic ulcer, or there could be a mixed pattern. Okay, so not all diabetic ulcers are ischemic. Most of these ulcers are neuropathic. I think that's where there is no scope for any kind of confusion. Okay, all diabetic ulcers are not ischemic, but there could be always a mixed pattern. So that's why you have to find that. Today, the patient that you were saying had neuropathy.
Yes,
and
sir.
neuropathic ulcers are the ones which are present in which areas of the foot neuropathic ulcers would be present.
Aspect, where the pressure area, sir.
Exactly, there will be pressure present at the pressure points.
Pressure points.
Yes, I'm very happy that boys in the meeting, those who are attending this program, they are answering these questions very nicely, and I'm very happy that these would make for a very nice kind of presentation, and also it gives me a feeling that you have come prepared with some kind of background activity. That's very nice, right? So there has to be a very comprehensive kind of understanding. Okay, so we have discussed about the gator area, we have discussed about the venous ulcers and the arterial ulcers, and we have given you an idea how to differentiate the two. Now, what else do we need to talk about? First and foremost is, whenever you are seeing, there has to be an approach to these patients. Now, first and foremost is that you should know the current way of classifying the varicose veins. And you know it's a CEAP. C stands for?
Sir, clinical classification, sir.
Clinical classification.
E is etiological.
E is etiological.
A is anatomical, and P
anatomical.
Is and pathological, sir.
P is pathological. So what is the C?
Sir,
every one of us should be able to assign a accurate C to all our patient of varicose veins. Varicose veins is a diagnosis of inspection. You see that dilated. What is varicose veins? Can you define varicose veins?
The dilatation more than 3 millimeters, or in a Doppler, if there is a revegetation, if there is reflux of
wrong. Clinical. 3 millimeters too small. Anyone who can give me the diagnosis? I'm sorry, definition. Dilated tortuous vein. One word is missing here. Can anybody add? Yes, that's right. Bhavna, you are right. Dilated, tortuous, elongated. So what happens? Can you trace how the vein becomes varicose?
Yes, sir.
Yes, what pathophysiology?
Sir, one is saphenofemoral incompetence, sir.
So first is there is some kind of an incompetence that results in because of valvular failure, there is incompetence. Now there is more blood. To accommodate more blood, the vein has to become elongated. If the vein has to become elongated, and when it is enclosed in its own fascia, how can it do that? It becomes tortuous. There is a saphenous fascia all around the saphenous vein. And that is what you will be talking about when we talk about tumescent anesthesia. You know about tumescent anesthesia?
Yes, sir.
Okay, good. I think we'll take up these things, when we do our next class on Friday or Saturday.
Yes, sir.
Okay. So remember this very important thing. The definition of varicose vein is dilated, tortuous, and elongated. What happens first? First is valvular incompetence. And with that, there has to be a need for greater storage of the blood, or there is more blood which is going backwards, so the system has to dilate, right? And the system dilates, it has to elongate, and once it elongates in that situation, when it is covered over by the saphenous fascia, then it has to have that kind of a tortuosity. So dilated, tortuous, and elongated, that is how you would always call these varicose veins. Okay.
Yes, sir.
Okay, so C, as we were mentioning, every one of you should know how to assign a proper C to every patient of varicose veins. So tell us what is C in this patient, and first you tell us what is the various C grades, and then you tell us what is that in this patient.
Sir, C1 is telangiectasia or reticular veins.
It starts from 0. It's not 1. It starts from 0.
Sir, no, C0 is no visible or palpable veins, sir.
Yes, so you start with that, no? C0.
C1 is telangiectasia or reticular veins.
I think telangiectasia, not reticular veins.
Okay, both come.
What is the difference between telangiectasia and varicose veins? Can
sir, less than 1 mm and 1 to 3 mm, sir.
Anybody with a different idea? Or it is just the size that makes them telangiectasia? Telangiectasias are intradermal veins. Somebody is right. Yes. Somebody is given it right. 2 persons have given the right answer. These are intradermal or subdermal, right? They have no communication with the axial veins. Got it?
Yes, sir.
When reticular veins are the ones which have the communication with the, they're small veins less than 3 millimeter or so, which are having some communication with the tributaries of the axial system. And when the axial system undergoes dilatation, then it starts as C2. C1 is telangiectasia, C2 is reticular, C3 is
Sir, C2
axial
is
vein.
varicose vein, sir.
Huh?
C2 is varicose vein.
Okay,
C3 is edema.
okay.
And C4, there is 4A, 4B, and 4C.
Mm-hmm.
4A is pigmentation.
I think your classification is dated. It is changed.
Sir, this is the latest 2020 classification, sir.
Okay, so I maybe I was the one that I was reading was that it is that first is telangiectasia, then there's the reticular veins, then there's dilatation of the axial veins without any kind of edema or any ulceration. Two is next is varicose veins with edema, and next is healed ulcers, and next is the one which has got probably active ulcer or something like that. So can somebody read it out if somebody's
Sir,
got?
I have the classification, sir. This is the latest 2020 classification.
So read it out from your book. I think that will be better. Everyone should get clear about it.
Yes, sir. C0 is no visible or palpable signs of venous disease. C1 is telangiectasia or reticular veins.
Okay.
C2 is varicose vein. And
Okay.
in this, there is something called C2R. That is, R is for recurrent varicose vein. If it is R.
Forget about that. Let's not
Okay.
continue.
C3 is edema.
Okay.
C4 changes in the skin and subcutaneous tissue. And that is 4A, 4B, and 4C.
What is 4A?
4A is pigmentation or eczema. C4A.
Okay.
C4B is lipodermatosclerosis or atrophy blancae.
Okay.
And C4C is coronaphlebectasia.
Okay.
And C5 is healed ulcer. And C6 is
phlebitis is also called ankle flare.
ankle flare. Okay.
Right.
Yes, sir. C5 is healed ulcer and C6 is active venous ulcer.
Okay. Malleolar flare or ankle flare. That's right. So I think you should be very clear, and whatever classification you understand, you should be very clear about this and use this classification in the discussion of your case.
Yes, sir. And in Bailey and Love, they've also mentioned S is for symptomatic. A, they should also write S is for symptomatic, A is asymptomatic, and R is recurrent, sir, for any of these things.
Let's not bother about these hair splitting. Let's continue with what we have discussed. And I think you can pick up the latest classification, 20, or the one before that, and know the difference between the various stages. The most important, the most severest form is C6 or what is that other one?
Active venous ulcer, so C6.
Active venous ulcer, that is the severest form. And before that, of course, there is healed ulcer, ankle flare, and lipodermatosclerosis.
Yes, sir.
So that's what you should be very clear about it. So what is the stage where you would put your patient in?
So because the patient has pigmentation in the popliteal region, C4A, sir.
Is pigmentation in the popliteal region due to this varicose veins?
Yes, sir. At the level of the where there is varicosity, exactly on that spot there is pigmentation, sir.
I would be very surprised. And of course, I see that there is a pigmentation. And I'm a little confused about it, because generally what we see is that pigmentation happens around in the gaiter area, in the lower part of the leg. So that's the area which is affected by the ulcer, this pigmentation. So if the patient is having this pigmentation, you have to find out whether it is present only after the detection of varicose veins, or he has been having this ulcer, this pigmentation for some congenital condition.
No, sir. He had it only after this varicosity, sir.
Honestly speaking,
and that pigmentation also extend to the leg also, sir. A little bit on the leg also.
Honestly speaking, I don't know about it. I'd like to brush up my knowledge whether pigmentation occurs in areas as high as popliteal region or the thigh. I have generally seen pigmentation only in the lower leg in the gaiter area.
Yes,
So
sir.
that's my understanding, and I would like to correct it. I'd like to have your feedback in my next class, whether if the patient is having any pigmentation in a patient of varicose veins higher up in the popliteal region or in the upper thigh, should we be considering it due to varicose veins, or it could be due to some other reason? I am honestly, my take on this is that it happens in the gaiter area only, and the reason for that is that that's the area where there's a constant perforator, and that constant perforator, when it leaks blood, it causes deposition of hemosiderin pigment, and that brings about the blackness of the skin. So that's my understanding, but I would stand corrected if you can give me some other inputs from literature.
Yes, sir.
Okay.
So
So you
moving on
should be
to
able to assign. You should be able to assign C. So
Yes,
in
sir.
this, Shyam gives it because of pigmentation, but I will say that by and large, I will disregard this pigmentation and consider it as axial veins without any edema, and that we, I think,
C2 second,
C2 for me.
C2,
But for Shyam, it will be maybe C3 or C4.
C4A.
Okay, C4A. Chaliye. That remains a contentious point, and we'll sort out this contention in our next session. Okay,
Yes,
what
sir.
is E in this patient?
Sir, E is a primary, sir.
E is etiology,
Etiological
primary or
vessel.
secondary.
Secondary.
So we don't find any reason for this to be considered as
Secondary.
secondary. Okay, now anatomy.
Anatomy, it is AS and AP, so that is both superficial and perforator veins are affected. So AS and AP.
So in anatomy, what all we need to find out?
Sir, we have to know the deep venous system, sir.
So we have to, first and foremost, is we have to know whether it is short saphenous system or it is a great saphenous system, right?
Sir, usually anatomical, they are classified into either deep, superficial, and perforator. And
So
N is none of the above, sir.
let me complete it. Now, first and foremost thing is that we, by distribution of the veins, we have to assign whether it is a great saphenous system or a short saphenous system, right?
Yes,
So let's talk about the conventional things first, and then we can come out to whatever new thought process have been incorporated in it. So what is the distribution on the medial side? Varicosities are considered to be because of
great saphenous vein.
great saphenous vein. Okay. And on the posterior side or on the lateral side, they are considered to be due to short saphenous vein. Short saphenous vein. What is a great saphenous vein? Can you describe what is great saphenous vein?
So this vein arises above the middle malleolus.
It's not arises from that.
I mean, from the venous arch, sir, from the dorsal venous arch.
The medial end of the dorsal venous arch continues as the great saphenous vein, and it lies in front of the medial malleolus and goes along the this tibia on the shin, and then of course it courses in the thigh, and there of course it gets a name of common femoral vein. This becomes a great saphenous vein, and it joins the common femoral vein. Crossing the foramen ovalis. So that's the course that you have. Okay. So if there is a varicosity in this anatomical region, that will be considered to be because of the great saphenous vein, right? If there's a varicosity in the posterior aspect, on the lateral aspect, that will be likely to be due to the short saphenous vein. So first is you should be clear, great saphenous vein or a short saphenous vein. Then when you come to the great saphenous vein, whether it is saphenofemoral incompetence, or whether it's a perforator incompetence, or it is both, right?
Yes, sir.
So is it clear? So
yes,
when we are assigning A, first is whether it's a great saphenous vein or it's a short saphenous vein. Great saphenous vein, medial side, short saphenous vein, posterior aspect. Then when we are talking about great saphenous vein, you have to look at whether it is a saphenofemoral incompetence, whether it is a perforator incompetence, or it's a combination of both. So that's important that you have to establish. Okay. So
Yes.
what is that in this patient?
Sir, it is both. It is a saphenofemoral incompetence, sir. SF incompetence and as well as perforator incompetence.
Femoral incompetence and perforator incompetence.
Perforator incompetence.
Okay.
In perforator incompetence, it is a below knee incompetence present, sir.
How did you know that?
Sir, I did a test. There is actually two tests, sir. One is Tendelenburg 2 test, tourniquet test are present, sir. So in this test, or there is also a test called Fegan's test, where you look for the blowouts.
All this is nonsense.
So blowouts, you look for blowouts, sir, basically. And
blowout, that's where you have to be very clear. First and foremost is that only test which can be of some use is Trendelenburg's test, Brody-Trendelenburg test. Now, what is Brody-Trendelenburg test? There are two
tests, sir.
There are two components of this test. First is first you understand the basis, and then you know exactly how to do it. We block the saphenofemoral junction. So where the saphenofemoral junction is located, we use a tourniquet, empty the vein, use a tourniquet to block the saphenofemoral junction with adequate pressure, right? And then ask the patient to stand up and now open the tourniquet and see whether there is a rapid filling from above, right? If there is a rapid filling from above, it means that saphenofemoral junction was incomplete. In the second part of this test, you don't remove the tourniquet and see if there is a filling that is filling up these veins from below. If that filling is taking place from below, that means there is a perforator incompetence which is filling up the
superficial venous system.
Yes. And the next step is that when you remove this tourniquet, there is further accentuation of filling, and this time the rapid filling is taking place from the blood which is coming from above downwards. So this, you should know exactly how to do this particular test, and this test can tell you about whether it is whether it's a saphenofemoral incompetence or whether it is saphenofemoral with perforator incompetence, or it is perforator incompetence alone. The patient can have any combination, right? And this could be not necessarily when the patient has a perforator incompetence. The most common cause of perforator incompetence is, what is the most common cause of perforator incompetence?
DVT.
Anybody else? Yashika, Shivani, Parth, Saraswati, Deepak, Rakesh, Rajshri, Karan. Anybody? Long standing, says Ravi. Anybody else? So the commonest cause, remember, is primary, not secondary. So it's not perforator incompetence is because of deep vein thrombosis. Perforator incompetence is because of the idiopathic, or for whatever reasons the patient has primary varicose veins. Same is the reason for the incompetence of the perforators. Okay. So these are a few things that you should be very clear about. C, E, A. And in A also you have to assign which particular veins and all of those segments. I think you should read up A very nicely. What is P?
Sir, P is pathological classification, sir. Whether it is due to obstruction, reflex, or either both or none, sir. This is the classification, sir. In this patient, it is P reflex, sir.
Reflux, obstruction,
both or none, sir.
Yes.
None of them.
Yes. So I think CEAP is something which is a very important way of looking at varicose veins, approaching the varicose veins, and then planning treatment as per the inputs from these particular parameters, which we classically use the word CEAP.
Yes, sir.
So,
Sir, one
that
more
is-
thing in exam, the test for DBT
let
not to
me
be done.
complete. Another important point that you should know is Perthes test. Now, nobody will talk to you about 3 tourniquet test because it is very fallacious and very unreliable. Nobody now treats the varicose veins based upon the result of the based upon the results of the
Tourniquet
3
test.
tourniquet test. So, what is expected of you is to be able to do a good Brody-Trendelenburg test, and then you should know about the Perthes test. Now,
Yes,
what
sir.
is Perthes test, and what is the information that you get from the Perthes test?
Sir, there are 2 tests, sir. One is Perthes and modified Perthes, sir.
So nobody does Perthes test now. It's always modified Perthes test.
Perthes. Yes, sir.
Okay.
Modified Perthes test, you just use a you just tie around the saphenofemoral junction, and you ask the patient to walk. In this, there is a both subjective and objective manner. In subjective, it's if the pain is produced, it is due to deep vein thrombosis, and there is also objective it is dilatation of the veins, sir, superficial venous system.
Well, I think in modified Perthes test, the important thing that we are looking for is whether the deep venous system is blocked or it is open.
Open.
Right. If a patient is having a deep venous system blocks, right, and you do a modified Perthes test, what will happen? That these superficial veins will become engorged, dilated, and the patient will experience pain, right?
Yes, sir.
On the other hand, if these veins are patent, then these patients, these varicose veins will become less prominent.
Sir, in this, first we need to rule out perforatory incompetence before we do this test, sir.
So I think I'm not too sure about that, but
Sir,
anyway,
because perforatory incompetence, you eventually get dilatation of the veins, sir. So we need to rule out the perforatory incompetence and then do modified Perthes, sir.
For modified Perthes test, what does it mean? A modified Perthes test, what we are having a tourniquet which is blocking the superficial system, right? Now, if deep system is patent, right? So this blood will be now going all the way from the deep system, and this will not result in any kind of in engorgement of this superficial system. On the other hand, if the deep system is blocked, then what will happen is that this will become more prominent, and all this superficial veins of the leg will become prominent. So you just have a very standard, this is a very standard test, should be done in a very standard manner. And this is not the forum on which I'll be talking about the, detailed aspect of Perthes test. Pick up your book and read it thoroughly. And next time, we can come out with, whatever newer things that we have learned about it. Okay.
Yes, sir.
So you should know about Trendelenburg test. You should know about the Perthes test. And then there's something called Fegan test. Now, Fegan sign is something when you run your finger on a superficial vein, and you can see some kind of a give while running your finger in a particular area, that could correspond with a incompetent perforator. So that's what was thought to be, but it has not been found to be a reliable test. So Fegan test is just a historical thing. You should know a little bit about Fegan test. That is running your finger over the vein and looking for any kind of a give phenomena. And if there is a give there in that particular point, and it corresponds to any kind of blowout when the patient is standing, that may be the place for a incompetent perforator.
Yes, sir. And one more thing, it was mentioned that Fegans is done in a lying down position, sir.
Fegan will be done in the lying down position, but blowout will be seen when the patient is standing.
Standing.
Because when the patient is standing, only then the veil will.
It is visible during standing, but when you feel when it's lying down.
So Fegan test, that's what I'm saying. When the patient, you are running your hand on the vein, collapsed vein, and you find a feeling of give. That is Fegan sign. In that, when the patient is having emptied veins. When the patient is standing and you are seeing areas of more engorgement than the rest of the vein, that is an area of blowout.
Yes, sir.
Blowout in the standing position, and feeling of give when the patient is lying down. So these are the two things that you should be aware of.
Yes, sir. And moving on to the next examination, sir, there is no inguinal lymph node.
I think we have finished our time. We can now conclude.
Conclusion, sir. Here we have a 40-year-old male patient having engorged, having varicose vein of classification C4, C2, EP, AS, AP, and P reflex, sir.
Okay.
P reflex, sir.
Right. So you have this patient. Would you like to do any test on this patient?
Yes, sir. A Doppler.
So today,
venous Doppler, sir.
All the patients of varicose veins are operated after having a proper evaluation with a 2D Doppler study.
Yes, sir.
2D Doppler study will we look at the deep venous system and have a clear idea about the deep venous system. Number one. Number two, we'll see where the incompetence lies, whether the saphnopopliteal or it is perforator incompetence or a combination. And we can also mark out what is the site of incompetence, perforator, and whether that perforator is significant or it is not significant. When do we say that it's a significant perforator incompetence? Anyone? Anyone can you say when can you say that it is a significant perforator?
When Trendelenburg 2 test is positive.
No. On ultrasound, on Doppler ultrasound.
Sir, when there's a reflex.
3 millimeter in size, and the reflex takes place for 500 milliseconds. Okay. So
yes,
as we mentioned, there could be hundreds of perforators. We are not looking for the perforators. We are looking for a significant leaking perforator. A significant leaking perforator is one which is more than 3 millimeter wide and which is where the reflux is taking place for over 500 milliseconds. So that is a perforator which is of importance to us.
Yes, sir.
So what will you do for this patient? Now we know that patient has perforator incompetence, patient has saphnopopliteal incompetence, and patient is in front of you.
Yes, sir. Sir, first I'll completely evaluate the patient, sir.
You have evaluated the patient. What more? No,
sir. I will evaluate even ECG and echo to confirm there is no any cardiac abnormal cardiac involved. All cardiac functions are normal.
Why do you worry about that?
Sir, even due to right heart failure or it can cause.
Why you bring in right heart failure at this stage? This is not on. I have not seen a patient of right heart failure with varicose veins.
Yes, sir.
Have you seen one?
Sir.
You evaluate every patient from the point of view of fitness for anesthesia. That's fine.
Yes, sir. Then ultrasound abdomen to rule out any abdominal any abdominal lump and all, sir. Then
generally in a patient where our diagnosis is the primary varicose veins, we generally don't do unless there are some features suggestive of secondary phenomena taking place.
Yes, sir.
Okay.
Then after a routine all routine blood analysis, I will give various options to the patient, sir. Various treatment options.
You don't give options to the patient like that. First is are you clear what you're going to do?
Yes, sir. One is the conservative therapy, sir. Where you give stockings, where you give pressure, where you give stockings, sir. Pressurized.
So unless, now be very clear, unless the patient has complications of varicose veins, the treatment is conservative by and large, unless patient is having symptoms which are not controlled by the conservative measures. So first treatment for varicose veins is conservative treatment, and that would mean that if the patient is having varicose veins without complications, without edema, without ulceration, without lipodermatosclerosis and other complications that we have discussed, if the patient comes into that category, that will be C3 or so, we would generally offer conservative treatment, which will mean pressure garments. And this pressure garment also having various types of pressure, 20 mm, 30 mm, 40 mm, and all depends upon the grade of varicose veins. So the pressure will generally depend upon the grade of the varicose veins. Higher the grade, higher will be the pressure that would be required, and lower the grade, lesser will be. So
there are various classes. UK guidelines have given various classes.
I don't think we have time to go into the details, but just remember it for the sake of remembering that it will all depend upon the grade, and would generally start with 30 mm and then move sequentially if patient is not getting enough benefit. Then, of course, telling the patient the need for doing exercise, avoiding standing for the long hours and things like that. If the conservative treatment doesn't bring about the desired change, then patient can be offered surgery.
Sir.
So first and foremost, for C3, up to C3, the treatment is conservative. Patient not controlled by conservative treatment, right?
Yes,
when
sir.
the conservative treatment is not successful, then only, or if a patient is having cosmetic reasons, or sometimes, in the Indian context, we get the patient, have to go for some kind of a occupational fitness test, like going going to army. They don't want they don't want a person with varicose veins. So the patient may come with that kind of an indication that he has been rejected by a medical board. So you may have to offer such treatment to these patients. So you remember, the primary treatment for varicose vein without complication is conservative treatment, and the most important aspect of that is exercise, change in hours of standing, change of occupation, or maybe getting to a situation where the person is not standing for long hours, and using some kind of arrangement where one can keep one's legs raised above the level of the heart by 15 centimeter 30 minutes in a day or so. There is some kind of a recommendation on that. You read up from your books on that. Okay. And there is some role that people say of what is called as phlebotomic drugs like Daflon and diosmins. There's some role there. So the conservative treatment is the treatment for conditions up to C3. After that, of course, we'll have to consider some kind of surgical treatment for these patients. And failure of conservative treatment is also an indication for surgical treatment. As the surgical treatment and other aspects are concerned, we can take them up in our next class.
Yes, sir.
There's so many chat questions. Let me see if there is something that we can answer.
Sir, Biscard has been only for ulcers and not for Biscard's regimen. Someone has mentioned is only for ulcers. Conservative treatment for ulcers.
That is Unna boot. Okay. Somebody asked about tumescent anesthesia. We'll discuss about it in our next class. That's more important when we are doing these endovenous procedures for endovenous procedure for the varicose veins, right? And okay. Can't move my cursor. I think by and large everything has been discussed that we wanted to. And thank you everyone for joining in this session. And thank you, Shyam, for bringing in a nice case for discussion.
Yes, sir.